Good afternoon. First of all, I would like to thank Professor Step that he and his team provided us the opportunity to share our research work with you. And thank you very much for your kind introduction. So since we have little time to finish, so I will try to do it timely. I hope so. So this study is in Himalayan mountain villages. It is in Gilgit-Baltistan, which is a new province recently created. So it is a mountain population, and 60% of global tallest mountains are located in this area. Can you next? Can you? Can I change here? How I change here? Oh, this one. Okay. So as you can see, that it is a beautiful area, and it is high mountain population, and in this beauty and everything, the the healthcare providers is a big problem. For example, in this study, the only people who could treat people with depression were physicians. So I had to request my class fellow from Karachi to come and train physicians so that whenever there is a referral, they can treat. So there was no single psychiatrist in the whole population of 200 million people. So why this particular area? There was some very interesting studies in the past when this area was part of British Empire. And Robert McCreeson, the Oxford University president, in this particular village, in this surrounding area, conducted a number of studies, and he published 8 papers in British Medical Journal. And one of the things he noted in his study was that these people were living very long, like beyond 95 years, and that the people were one of the happiest people on earth, according to his studies. So they were working all the time, but very happy people. A village was like a family. So they were working in collaboration with each other. So two things I just wanted to tell that this is an area where there was a very nice program was initiated by Aga Khan Foundation and Aga Khan University in partnership with the government. And the infant mortality rate over this period of time was reduced from 158 to 29 in these remote villages compared to the national average of 95. So this was very successful program. And then rapid improvement in education. So suicide was totally rare. That there was, you can see that illiteracy went from 158 in men to 24, and similarly you can see very rapid improvement in education of females. In this background, I was planning to conduct a study on, so this is education in females. You can see very much improvement over a short period of time. Sorry. So this was okay. So this was the method, so what I did was I took a train nurses from Aga Khan University, highly qualified nurses, a team of nurses and a team of medical doctors from Aga Khan University, and then we prepared this study, and we got all the information. Any suicide happened in the area, we got from the police records, and Aga Khan Health Service, a community-based program, so they note any suicide in any village. So we got this. So we had complete list of these suicide cases which occur over a period of 10 years. So since it started, it was previously totally unknown, never happened. So, so you can see when we calculated the suicide rate, so the total number of suicide and from the census population denominator, you can see it is one of the highest, and unlike any other study, the suicide rate is higher in females than male. And there was no good study done in Pakistan, so we could not compare from data from Pakistan. So we compared with some of the figures that it is huge problem. And you can see in what particular age these suicides are happening. When you look at the global data from US or Canada, it is older people. Here you can see almost and 95% of these are under 40 years. So and the typical age is 10 to like 20, 24 years, where you can see high rate of suicide. The other thing was, when we look at how many who committed suicide, how many were married and unmarried. And you can see that a lot of them were unmarried. So very young kids, unmarried kids. And then you can see the education. As I showed you, that education has too much improved. But when you look at, so we look at those where they committed suicide, see the education. The mother-in-law is like 95% illiterate. And look at the daughter-in-law which committed suicide in the household. They are highly educated. So this is a major issue of the people, the young generation, the old generation. The old generation a totally different viewpoint. And they think that the young generation who are educated should act like what they were doing as a, daughter-in-law. But the new generation, they expect more, because they're, in 95, I conducted the first population-based study in this population. There was no telephone, no cell phone. A woman cannot talk to anyone. If there was a message sent, the mail will go to nearby center, which was not available in village, in the main town, and he will call. But now, every household has, every child has a cell phone in hand. So these are these big changes, in this society. And then similarly, so unmarried children, they committed suicide, and we asked the education of their parents. You can see the parents have no schooling. So the suicide happened in those households where were less education in mother, less education in father and mother. So there was some problem. So the issue is more prevalent in those households, unlike those households where people are educated. This was very interesting point. You can see, just imagine that a lot of these suicides are occurring in spring and summer, and very few in autumn and winter. So I was wondering what is happening, because there are separate four subdivisions which are quite far away, 3 hours, 2 hours drive far away. So then I looked at if it is similar pattern in each of these subdivision. And then you can see in each subdivision, it is mostly in the summer and spring, very few in the winter. So this needs to be further explored. We could not get a definite answer why it is so. And then how they committed suicide. And you can see in female and the male. In female, one of the major methods to commit suicide is 50% to jumping in the river. What happens is that in every village there is water which is coming from upstream, so which is nearby. So maybe this is the reason the rate is high, because in other places they will use other thing where they will not die and they can be rescued. But here, once you jump in the river, there is no comeback. So that might be the reason that it is very high in females, unlike any population studied. And then what was the reason? So what we did in this study was, we got all the information from the household, and then we had in each team one doctor, one nurse, and one community health worker. And then they went to the household, they got the information. If it was a married person, they got the information from, father-in-law, mother-in-law. And then if it was unmarried, they got the information from parents. But what we did was that we identified the best parent of individual who committed suicide. So then we went to him or her, because they were the best friends. We got the real information from these people, because we got not a lot of information from the parents or from the mother-in-law, father-in-law. So that was very useful, because we got a lot, because they knew everything about this, why. And then you can see what is the problem. Some of the problem, they already had a depression, they were diagnosed, they were on treatment, but they died, The rest, you can see the love related affair. So in old days, what happened that the father and mother will choose you the girl you have to marry, right? In my generation, my parents will say, I will not even ask why you are saying that I have to marry. I have to accept there was the law, there was the tradition. But now the ladies are educated, they want to have their choice in selecting their partner, but that is not acceptable for parents, So that might be the reason that it is so high in those households where both parents are illiterate or one of them are illiterate. So the way they are dealing this issue, maybe, that these were, not, there were, I do not have time. I have described every event and we know detail how it happened. So there were a number of occasions, but the main key was that the parents wanted to marry this to one of their relatives, but the person wanted to marry someone else, but it was not acceptable for the parents. So that was one reason. The second was the mother-in-law was a huge problem because the mother-in-law, the husband will listen to the mother-in-law. She is the kind of commander-in-chief in the household. So she thinks that what she was doing several years back, her daughter-in-law, who is like graduate or a doctor or an engineer, she should follow what she was doing. And the young generation has totally different expectations. So this was another major problem. The third one was education related, because there is so much focus in education, like under 30 years, 97% children are educated. So there is too much competition. Some of them failed in the exam and then they committed suicide. That was a third important reason. Then rest, family discard and then financial issues. And these were in older people, particularly they had some chronic disease and they committed suicide. How much time we have? Okay, and then we asked, from where they were getting treatment. What was the source of treatment? And you can see, these are, this was the suicidal ideation. Data where, there were, this was another study we will ask. We took a random sample of 1,500 households from 3 districts, and where we assessed the suicidal ideation in people. So in them, the positive symptoms of depression by gender. So we look at the prevalence of depression, how it varies. Thank you. So how it varies by gender. You can see not only suicide, but depression, which is according to the other studies also. It is very high in females compared to male. And then in each of the districts, these were 3 rural districts. So overall, and then each district, you can see there is a disparity by gender in prevalence of depression. So these are self-explanatory. And then you can see, seeking health care. So those who have, suicidal ideation, they will not go to the doctor, because in Pakistan, it is a criminal activity. To think of suicide is a criminal activity, and they are not going to doctors that they will be, they will know it. So, and then those, help for suicidal ideation, you can see that very few get help. And some of them who attempted suicide, and then you can see there is also disparity by gender. And when we ask, from where they get treatment for the mental health, again, it is faith healer, the main provider, both for those who committed suicide and those who have suicidal ideation. The faith healer and then other people. So very few will go to doctor, and very rarely few people get the help of a trained psychiatrist in these rural villages. So it is a huge problem. One of the things is, as a public health person, for me, it is how to prevent these things, because these are social problems, how we can engage parents and how we can educate both the data, the females and males, how to,
You want me to do it
you
from
know,
here?
address these issues. So this needs intervention, population-based strategies. So it is very difficult task. So these were some kids I took picture when we were doing the survey. So it is the matter of future of these young kids. So how we work and how we prevent it is a huge challenge. So thank you very much for your attention.